Thank you. We can proceed.
Uh, Good evening and welcome to a star-studded webinar of ISAR UNS Fertility Catalyst webinars. We'll have an evening full of stars and a lot of insights from this meeting. This webinar, thanks to Dr. Amit Patki sir and Dr. Asha Bakshi ma'am, is the 13th in the series. While we debate whether it's a lucky or unlucky, but I'm sure from a childhood, we a toddler, we are moving into the teens and soon would be into the adult. Some of us may recall the Tezab song of famous Madhuri Dixit. Keeping all this aside, I am Dr. Manish. I am the Medical Affairs Head at Universal NutriScience, the collaborator with ISAR for this webinar series. I'll now request our Vice President and Business Unit Head, Mr. Nikhil Mehra, for his opening remarks and setting the context. Over to you, Nikhil.
Thank you, Dr. Manish. Am I audible?
Yes, sir.
Yes.
Thanks a lot for handing over to me. So before I begin, let me share a quick thought with all of you. So out of my total industry experience in fertility science domain, I am there for nearly 1.5 decades. And one thing I prominently learned that the journey of life starts with a single cell. And yes, you rightly judged, that's correct. That's the embryo. Yet behind this, one of the cell lies decade of science, experience, and the commitment. And that's exactly what today's program is all about, addressing the toughest challenges in IVF, the power of knowledge and the collaboration with, of course, the SR and the, eminent doctors from the country. A very warm good evening and welcome to each one of you to the 13th ISAR UNS Fertility Catalyst webinar series. I like to thank Central ISAR leadership team led by Dr. Amit Patki sir, who is ISAR president, Dr. Bakshi ma'am, our national conveyors, Dr. Anu Agarwal, Dr. Fassi Lewis. So, I was thanking them that the way they coordinated and ensured this event is seamless is really a commendable thing. Also, my sincere thanks to our chief guest, our guest of honor, and also to our esteemed speakers, including Dr. Nalini Mahajan, Dr. Naina Patel, along with the chairperson, moderator, and all the esteemed panelists and the delegates joining us today. This evening is focused on highly relevant topic, which is thin endometrium, poor ovarian reserve, poor responders, and ovarian rejuvenation. On behalf of UNS, along with me, today we have our medical team, our marketing team, and business team is part of this wonderful initiative. This evening is focused on highly relevant topic, and we at UNS deeply committed to support science, clinicians, and patients in their journey. And forum like these truly embody that the spirit of collaboration which we are proud of. With this, I once again welcome you all and wish everyone an insightful and enriching session ahead. Thank you so much. Over back to you, Dr. Manish.
Yeah, Saraswati, you want to get rolling? Saraswati, unmute yourself.
Yes, sir. Is my screen visible?
Yeah, visible.
Yes,
So, good evening, everybody. I'm Sanskriti Katkar from Medical Affairs team at Universal NutriScience. So, I extend a very warm welcome to everybody, every esteemed faculty members joining us today for SR Fertility Catalyst webinar series 13. And we are also privileged to have our chief guest, Dr. We are also privileged to have our chief guest, Dr. Kanti Bansal ma'am, and guest of honor, Professor Ashok Kumar sir. And also, this wouldn't have been possible without the support and blessings of Dr. Amit Patki sir and Dr. Asha Bakshi ma'am. And also without the support of Dr. Anu Agrawal ma'am and Dr. Fassi Lewis sir. So amazing. So, Dr. Anu Agrawal ma'am was director at Vanch Fertility and Test Tube Baby Center, Ayushman Hospital and Trauma Center, and Ayushman Multi Specialist Hospital. She has also published articles in reputed journals and written chapters in various books. Dr. Fassi Lewis sir is professor and attorney at Department of Reproductive and General Surgery at Amrita Ames Institute of Medical Sciences, Cochin, Kerala. He has also been affiliated with the several organizations, and he has also won several awards. For further proceedings, I would like to hand over to Dr. Anu Agrawal, ma'am.
Thank you. Thank you, Saraswati. So, a very warm good evening to all esteemed doctors present here. It is really an honor for me to welcome you all. for this 13th episode of ISAR UNS Fertility Catalyst series. First of all, I would like to acknowledge our dynamic ISAR President, Dr. Amit Patki sir, Secretary Dr. Asha Bakshi Madam, Vice President Dr. Sunita and Dr. Sujata Kar. Today's webinar, all about poor ovarian reserve and thin endometrium, is covering two very important topics which are tricky and difficult to manage as an ART consultant. So first of all, I would like to invite our ISAR President, Dr. Amit Patki sir, for his blessings. Amit sir, please.
A very good evening to you all, and thank you to UNS for having supported us in this excellent webinar. And thank you to Dr. Anu and Fesi, who have always led and ensured that this webinar is ever so successful. And I know that hundreds of people log into this and look forward because of the choice of topics and also more importantly, the choice of faculty. So thank you, Nu and Fesi. And to me, 13 is a very lucky number. So I'm glad you'll have reached this milestone, and I'm sure you will go much more ahead and you will continue to do the good work. Dr. Kanti Bansal as chief guest and Professor Ashok Kumar as guest of honor is a blessing to us because both are very senior and Kanti is one of the founder members for ISAR. So thank you so much, Dr. Kanti and Dr. Ashok Kumar. Dr. Nalini Mahajan and Dr. Neena Patel are always a dream speakers because they always come up with facts, figures, research, well thought out and well analyzed lecture. So I look forward to listen to both of them and then to the panel that will follow. So thank you once again. Thank you to to Mr. Nikhil and to Dr. Manish Garg and all those at UNS who have always supported ISAR not only in this webinar but also in the last two master classes that we have done. So thank you so much and thank you to all the listeners, and I hope we have a good 2 hour enriched and we come back with many more take-home message. Thank you.
Thank you, sir, for that, as usual, inspiring words of wisdom. I think, is Dr. Asha Bakshi logged in?
Dr. Fesi, Dr. Asha Bakshi, she's in Georgia and she has sent a beautiful message for all of us. Mr. Nakul, please share that message.
Yeah, we can. My screen is visible. Is it visible?
Yes,
Yeah.
Yes,
yes.
sir. Is it?
Very good evening to all of you. First of all, I would like to congratulate Dr. Anu Agrawal and Dr. Series for doing this Fertility Catalyst series, which is the 19th episode. So it shows that how popular it has been. It is being conducted since so many days. Under the leadership of ISAR President, Dr. Amit Patki, lots of webinars are going on, and this is one very successful one. And I would also like to welcome Dr. Kanti Bansal and Dr. Ashok Kumar, who are the chief guest and guest of honor. And the topics selected are really good, especially the thin endometrium, which would be taken by Dr. Nalini Mahajan, and ovarian rejuvenation, which will be taken by Dr. Neena Patel. So they are all stars in themselves. And then to send the video because I'm traveling, but it's always nice to remain connected. Thank you.
Thank you, Dr. Asha, for that. I mean, as usual, always she give the blessings, and even while she was traveling, she remembered to convey the message to all of us. Over to you, Anu.
So first of all, I would like to invite our today's chief guest, Dr. Kanti Bansal, who is my mentor.
Thank you.
Please share ma'am's CV.
Ma'am, just give me a moment.
Yeah.
I know it's okay.
We all know, ma'am, we all know you, and we all love you.
Thank you.
That's true.
There you go,
Ma'am
ma'am.
is director of Safal Fertility Foundation, Ahmedabad. And she's pioneer in the field of ART at India and Gujarat, pioneer in artificial intelligence, virtual reality, and haptics in ART. She has been awarded RCOG Distinguished Service Medal, specialized in management of infertile couples, PCOS, endometriosis, and women's healthcare. She has published 12 books on PCOS, endometriosis, infertility, and ART, and guide to PhD students and visiting faculty at Gujarat University, and successfully trained more than 2,000 gynecologists in the field of PCOS, endometriosis, and ART. Over to you, ma'am.
Thank you so much, dear Anu. At the outset, good evening, all my friends. And I want to thank the president of ISAR, Dr. Amit Patki, my very good and old friend, and also the president, Asha Bakshi. We are friends from many, many years, even before, I joined post-graduation. And all best of everyone is my dear Anu. She is not only my student, I will call you student. I keep calling all of you students. I'm sorry for that. But my really very good friend. I've learned a lot from her too. She's the most sincere girl that I have ever come across, and we need to really look up at her and learn many things from her. So, first of all, I want to tell that ISAR is doing tremendous good work in the field of education programs for clinicians. And today's both the topics are very interesting and at the same time difficult to handle in day-to-day practice. I think you all will agree with that. What a good choice of topics and what a good choice of speakers. I can also say what a good choice of the chief guest also. So, anyways, so coming to the thin endometrium, just a few lines I want to tell you all. First of all, we need to correct reversible causes, hormonal imbalance, infection, additions, optimize medical therapy, high dose estrogen, extended aspirin, vitamin E, and vascular and adjunct therapy is also there, sildenafil, oral or vaginal, pentoxifylline. Then we have the regenerative therapies, intrauterine GCSF, PRP, stem cell therapy, and Dr. Nalini Mahajan. She is my very good friend. I've been liking her very much from when I was also young, and we both have worked together for quite, and we both used to vibe very well because of our thinking, etc. And she's an expert in her subject, and I think she's a very good choice for this very difficult topic. Now, the next topic is on ovarian rejuvenation, and who else can be a better speaker than my dear friend, Naina. Naina is like, I really salute her, and we also vibe very well. So, if here in ovarian rejuvenation, Naina, I'll give my input, but then you'll have to give everything else. So, patient selection is very, very important. We have to exclude the reversible causes, then adjuvant medical therapy is important, and also we have to we can give like androgens, CoQ10, growth hormone, optimize, take care of metabolic and endocrine status, Then regenerative therapies, I think this is where Naina is doing a lot of work. Intraovarian PRP, stem cell transplant. It could be also bone marrow transplant, and advanced therapies, mitochondrial transfer. I think she may tell about mitochondrial transfers as also, and also in vitro activation of dominant follicle. And again, monitoring and individualization is very important. And last but not the least, our dear Rohan Palshetkar, the young and energetic boy, my best friend, Nandita's son, and he will be doing a panel discussion on poor responders, which is like an ocean, believe me. And once again, I thank UNS, Manish and Nakul and Sonu. I want to call you Sonu. I like that name, Sanskriti, and all the others in the UNS team. So happy learning and all my good wishes to all the delegates and all the faculties and UNS. Thank you so much.
Thank you, madam, for that words of wisdom. I think it is always our blessing to have you here as our chief guest. Thank you, madam.
Thank you.
Thank you, Kanti ma'am, for your kind, beautiful words. First, now, I would like to invite our today's guest of honor, Dr. Ashok. Here.
I'm not seeing, sir, I think. Hello.
Yes, Dr. Ashok.
Hello.
Dr. Pesi, he just left.
Oh.
Yeah.
Maybe some emergency.
Yeah.
Okay. I think we will join once. We will hear from him once he joins back. Before that, we will go for our first talk. We have the management of thin endometrium by Nalini Mahajan madam. I think to chair the session, we have Dr. Kunju Moideen, Dr. Varsha Basta, and Dr. Vijaya. And Dr. Kunju Moideen, and Dr. Anu, can you take? Hello.
Yes, Doctor. Yeah. So Dr. Kunju Moideen, he has 27 years of experience in the field of reproductive medicine and gynae endoscopic surgery. And he is immediate past president, Kerala Federation of Obs and Gynae, medical director of Birla Fertility, ARMC IVF. Welcome, Dr. Kunju Moideen. Next speaker, Dr. Varsha, Dr. Baste madam. She is practicing gynecologist and infertility specialist in Nashik since 30 years. She is director, Baste Maternity Hospital and Pushpa Fertility Center. She's Foxy Vice President, West Zone 2526. First PGD baby in North Maharashtra. She's past president, OBGYN Society, Nashik, and chairperson, Foxy IAEC. She has won prestigious Dr. Anandibai Joshi Award. Welcome, madam.
Thank you.
Next chairperson is Dr. Vijaya. She is clinical director of Vijaya Fertility Center, Pura Bartikhani and Mancherial, Telangana. I hope I am pronouncing rightly. Sorry, Dr. Vijaya. And she's trained in medical diagnostic ultrasonography from Nagodi's Institute, Ahmedabad, and she has taken her ART training from Rainbow IVF Agra. And she is Associate Professor, PIMS Karimnagar, President Foxy Karimnagar, faculty at State of National Conferences. Welcome, Dr. Vijaya. So
Thank you so much for the
over to you, chairpersons. Kindly invite our today's speaker.
Yeah, it's a great honor to be here for this on this ISAR platform. I'm really happy to be here with our friends, Dr. Patki, Dr. Kanti Bansal, Dr. Naina Patel, Dr. Fesi, Dr. Ashok Kumar, and all the panelists also, Dr. Rohan and everybody who is involved here. Anu Agarwal, you are doing really good work. I can see Jyoti Bali also, many Priyankur Rai, so many of friends. It is really refreshing to meet everybody on this platform. And the subject is also very nice. The thin endometrium orient regeneration is very discussed. So over to Dr. Nalini Mahajan. Who doesn't know Dr. Nalini Mahajan? She is such a wonderful person, so sincere and doing her work all the way since decades. And I cannot read her CV very well because it is very minutely written. But I know Dr. Nalini Mahajan has really revolutionized infertility treatment since long, and she really presents with research oriented. Depth of knowledge is really good, and every time there are many take home messages from her talks, and I really wish to looking forward to hear from her about the management of thin endometrium. Over to you, Dr. Nalini Mahajan, madam.
Thank you, Dr. Varsha, for these very kind words. And with that, I think we can start the presentation. Please tell me if you're able to see the slides. Are you able to see the slides?
We can see you, madam.
Or you can see me, but you can't see the slides.
No.
Not yet, madam.
Not able to see Nalini.
Okay. And when we just did it a minute ago, it was fine, and now suddenly it's not fine.
I can see Geeta Khanna, madam.
Yeah.
Sorry, madam, not missed taking your name. There are all my friends, but time restraint is there. It's already 7:30.
So now what has happened here, I don't understand.
You just shared, madam, na?
And that's what I was doing, but that's what I did, and we did it initially, and everything was fine. And now
UNS team,
suddenly,
please help her.
Yeah.
Technical advice, madam, to them.
Sanskrit, do you have the Dr. Nalin Mahajan slides?
no, I don't think anybody has my slides because they didn't ask for it. So,
You can send a mail, madam, just now.
No, I think we'll manage. It should not be so difficult to manage. I don't know why it's not suddenly.
Just here on the screen. Yeah.
Yeah,
Yes,
now it's
started.
screen.
Okay,
Yes.
you can see
No,
that.
only the okay, yes.
You can see that now.
Screen? Yes.
Yes, make it full screen, madam. Okay,
good.
Perfect.
Done.
Yes.
Okay.
Perfect.
So we're going to talk about management of thin endometrium. Sorry for this little glitch. So basically, one of amongst the prognostic markers of endometrial receptivity of the endometrium ultrasound based, that is the one clinical application actually that we have to look at receptivity. Endometrial thickness is the one which has been most studied and most correlated to pregnancy outcome after fertility treatments, especially IVF. And we know, of course, that we measure the endometrium from one junctional zone to the other in the longitudinal plane of the uterus. Now, what does the endometrium reflect? In the follicular phase, it reflects the bioassay of estrogenic activity, that is acquisition of estrogen receptors, and that then allows for progesterone action. In the secretory phase, reflects adequate maturation. And we consider an optimal endometrium to be a triple-line multi-layered pattern, which is 7 millimeters or more on the day of the LH surge. So therefore, by that token, a thin endometrium is considered to be one which is below 7 millimeters on the day of the LH surge. And the incidence in IVF is around 1 to 2.5%. So why does this become important? Because an analysis of over 40,000 embryo transfers has shown that if the endometrium is less than 7 millimeters thick in a frozen embryo transfer, you will have lower clinical pregnancy and live birth rates. And if the same is less than 8 millimeters in fresh transfers, you're again going to have a lower pregnancy rate. And even the guidelines suggest that, if you're finding that the endometrium at the time of transfer is less than 7 millimeters, then please counsel your patients, and maybe you can even defer the transfer till such time you're able to get a good endometrium. Why do we do that? Because reproductive problems are associated with thin endometrium. The first and most important one being, a decreased implantation rate, a decreased pregnancy rate. Even if they get pregnant, the abortion rate is higher because placentation is defective. And later on, you may have adverse obstetric events like PIH, abruptio, etc. Now we know that one of the theories, it is believed that the embryo is too close to the basal layer, which is rich in ROS, and that is detrimental to implantation and development. Or perhaps there is malfunctioning of the endometrial stem cells, and that leads to an incompetent or a thin endometrium. Now we know that every menstrual cycle, from the time the endometrium is shed during menses, there is a regeneration of the endometrium through the cycle. So in the follicular phase, there'll be growth, and then there's maturation in the secretory phase once ovulation has occurred and the LH surge has occurred. Now this regeneration starts from the stem cells, which are in the basal layer, and they are lying within the stem cell niches, which are in the perivascular space. Now, the interesting thing here is that the stem cell niche requires estrogen to activate it. However, the stem cells per se do not require, they can survive without estrogen. When we look at the causes of thin endometrium, we have the pathological causes, which are infections such as tuberculosis, which is the commonest in our country. We have bacterial infections, we have chronic endometritis. Now, we may also get thin endometrium because of iatrogenic reasons, for instance, surgery, or even ovulation induction drugs like clomiphene, even letrozole or arsenics, which lead to a high estrogen metabolization, and therefore, the endometrium remains thin, psychotropic drugs, or even smoking. Then congenital things like Turner's, and if there is an increased uterine artery impedance, then again the lining is not going to grow. But perhaps the worst and the most annoying is the idiopathic, where we cannot really pinpoint your finger as to why, what is the reason for this lining not to grow, and why is it remaining thin when there is actually no cause itself. And perhaps it is thought that there is some malfunction of the endometrial stem cells. In all the disease processes and the iatrogenic, what you find is damage to the endometrial stem cells in the basal layer. But in the idiopathic one, those are intact, but there is perhaps a malfunctioning which is not allowing them to grow. Now, this is a recent study which was done, which looked at the transcriptomics, profiling of the human endometrial cell. And what they saw in thin endometrium was there is insufficient proliferation of the endometrium because of cellular senescence. That means the aging and atrophy of the stromal and epithelial cells in the perivascular niches. There was collagen over-deposition around the blood vessels, and there was decreased number of macrophages and NK cells, which therefore then were impeding the growth of the endometrium. And more interestingly, the signaling pathways were aberrant, and these signaling pathways then inhibited proliferation of the stromal cells, and we know that it's the stromal cells which are the maximum which are responsible for endometrial growth. Now, injury contributes to accelerated aging. It has been seen that when there is injury, it accelerates senescence, it leads to immunocompetence and dysfunction, and this then perhaps impedes endometrial proliferation, apart from, of course, disrupting the vascular development and alters the receptivity of the endometrial lining. So how are we going to manage this when we are confronted with this thin endometrium? Of course, first of all, we investigate, and the gold standard for investigations remains the hysteroscopy. it is diagnostic, and it is suggested that it may be therapeutic, that the injury in itself leads to an immune reaction and some kind of a reactionary increase in the endometrial thickness. However, we do not have much proof of that, but it is one of the theories which goes around. Now, when it comes to drugs like clomiphene, letrozole, estradiol, those arsenics, etc., the best way, of course, is to, if you're like on arsenics and all, you need to finish your ATT. But if you have a patient whom you have given letrozole and you find that the endometrium is thin, please do not carry on and on with the clomiphene, because it has a cumulative effect on the endometrial receptors, and sometimes patients who have been on prolonged clomiphene will take almost 6 months for a year to have a rejuvenation of their lining. So this is one very, very important thing which people don't realize, because most gynecologists are not doing their own ultrasounds, so therefore they can't see what's happening there. If there is a thin lining, please do not use letrozole, clomiphene, and change it to another drug or another form of ovulation induction. Of course, we have to be careful when doing surgery that we don't do extensive curettage, and radiotherapy one really can't do much about, because if the patient has to receive it, well, they have to receive it. Now, management of how do we manage if it is chronic endometritis? Generally, you know that in tuberculosis, both with the treatment as well as with the disease itself, the healing is by fibrosis. And when it is by fibrosis, the basal layer of the endometrium is damaged, the stem cells are damaged, and therefore we'll have adhesions there, and very, very difficult, even after it visualizes, to actually get those stem cells going and getting back into forming, regenerating the endometrium. So far as chronic endometritis is concerned, this is generally an asymptomatic or paucisymptomatic problem, but on hysteroscopy, you'll see this, strawberry appearance. You may see micropolyps there. You can diagnose it by doing histopath with the IHC staining for CD138 cells. And if you have more than 5 plasma cells per high power field, it is indicative of chronic endometritis. The treatment is really very simple. It's either doxycycline for 2 weeks, or Ciplox for 2 weeks, or Metrogyl for 2 weeks, and it resolves fairly well. But you need to do a repeat biopsy, because there is still a small percentage of people who may not respond to these drugs, and then perhaps you may need to give them for a longer time. So what are the proposed treatments? As Kanti said earlier, you have hormonal treatments. Of course, your mainstay is estrogens and high doses of estrogen. When you use drugs for ovarian stimulation like tamoxifen, gonadotropins, they also, by increasing the endogenous estrogen, may help to improve the lining. And some people have also used HCG priming in the follicular phase. You try to improve the vascularity through drugs. And then, of course, very importantly, today we have the regenerative strategies, which is growth factors in the form of PRP and GCSF and stem cells. Now, estrogen administration, we all know that when we are doing a frozen embryo transfer cycle, we will give HRT in the form of Proganova. We start with 6 milligrams a day, but in these people, you may need to go much higher doses, and you continue, progressively to increase the estrogen, both duration and dose, till your lining starts showing up. You change the route of administration sometimes. You give vaginal as well as oral. Very occasionally injections, they are not so freely available. Or you change modification of the molecule type. For instance, instead of giving estradiol valerate, some people respond very nicely to Premarin. So change them over to Premarin. So it is always a hit and trial method which you keep changing and trying to see how the lining is going to grow. And you sometimes need to give repeated cycles of HRT. That estrogen stimulates that stem cell niche and gets the stem cells to start growing. Now, with the drugs, I'm not really going to go into this because we don't have so much time, but these drugs are used, and they may perhaps, especially tamoxifen or HMG, really work sometimes very nicely by increasing the endogenous estrogen. Now, HCG has been given both locally and in the system. But again, we don't have much evidence that it really increases the endometrium. Of course, there are always studies for and against the whole thing. So when we look at hormonal treatments, mainstay is exogenous and endogenous estrogens. HCG is not recommended, and GnRH agonists, they are not recommended. Then again, drugs to improve vascularity. One of the theories we say is that, the vascularity is compromised, and when you improve vascularity, your growth factors and all the other elements will, flow nicely into the endometrium and perhaps coax the stem cells to start doing and start getting proliferate the endometrium. So sildenafil, pentoxifylline, vitamin E, arginine, nitroglycerin, all have been used. Sildenafil is the only one which has shown a little bit of promise. Again, the strength of evidence is very weak. Now, aspirin is another drug which is given, I think, across the board. Almost everybody gives it because it is thought to minimize inflammation, it improves the blood flow, but actually there is no beneficial effect on embryo implantation in IVF as has been seen. It may improve a little bit of the vascular flow or the lining, but in terms of outcome, it is not going to do very much to the outcome. So again, most of the drugs, uncertain effect. Aspirin may have some effect, but we still don't know. We are not yet confirmed on this. The important thing now is the growth factors which have come in of late. We know that there is an embryo endometrial crosstalk, and there are a lot of growth factors involved, a lot of cytokines which are involved in this crosstalk, and this allows the endometrium to sort of open up for the embryo implantation. So GCSF is seen to be expressed on the receptors of on the trophoblastic cells. You have receptors of GCSF, and therefore it is thought that it is a growth factor, it is a cytokine, it stimulates the granulocyte proliferation. So it's thought that if when you give it either intrauterine or subcutaneously, systemically, there is some perhaps by supplying the growth factors helps the endometrium to grow. But again, we don't have any definite dose that you have to give, when it has to be given, how it works, and again, evidence for and against it. But nothing really to suggest that yes, outright that give GSF and you'll find some sort of an improvement. So we come to regenerative therapies, which are now actually the mainstay of treatment now, because they're doing really, really well. And of these regenerative therapies, clinically applicable ones are the platelet-rich plasma and stem cells. We have others which are research-based, and we're not going to go there. Now, platelet-rich plasma, we know, is being used more and more these days. So platelets contain a lot of growth factors and cytokines, and we know that platelets are associated with healing and regeneration, and they also have an antimicrobial activity. So the concept is that you actually concentrate the platelets from the blood, from the plasma, separate them out, and you need at least 5 times the baseline for them to be effective, and that's what's the presumption at the moment. That means at least 1 million per microliter of platelets, so that the growth factors then which are released into the tissue or released into the endometrium would start the process of proliferation, cellular proliferation. So basically you take 20 ml of blood collected in a ACDS solution, and it's centrifuged first for about 10 minutes at 200 G, and you separate out the plasma layer and buffy coat, and then you recentrifuge at 500 G for 10 minutes, and the pellet that you have, then that is mixed. The platelet pellet is mixed in a little bit of plasma, and then that is either activated and used, or you can use it directly and allow for activation within the internal tissues. Now, when you activate it, the action then lasts for a shorter while. So, mostly I don't use any activators and I prefer to use it absolutely directly. And the volume that I like to use is about 0.4 ml and not 1 ml as is suggested, because when you put in, through an IUI catheter, or you put it into the uterus, if you have more than 0.4 ml, it is going to trickle down. And when you are putting it into the uterus, you should push a little, wait, allow it to disperse in the endometrium, push again a little bit till you have completed. And so it should be a slow administration. And if you're doing it purely for endometrial thickness, it should be done early in the cycle around day 5 or 6. But if you're doing it for receptivity, then perhaps around day 9 or day 10, when your progesterone you're going to start administering progesterone. Now, it has also been administered hysteroscopically. You do a subendometrial injection. Personally, I'm not really very fond of it, because you're distending the uterus with fluid, and you should collapse the cavity if you're going to inject and then withdraw, because it is going to leak out from there. That is one. The other thing which always worries me, are we going to increase any adenomyotic element if you're going to push this straight into the subendometrial space? So the first paper which came out was by Chang, which became so viral, and everybody started using it, which showed that even in Asherman's and severely thin endometrium, we could regenerate the endometrium and get pregnancies. And then, of course, there was a host of other papers which confirmed the endometrial growth as well as implantation. So we decided to look at this. I decided to look at it in my clinic. And so we looked at two elements. One is, does it improve endometrial growth in women where the endometrium is below 6? I do not take 7, because there are some people inherently whose lining will not go above 6.5 or so. And then in those patients, there is really no point in going on and on. We have, if it's receptive, it'll hold. Then the second part we looked at was receptivity in terms of women with RIF, and in women who had failed personalized embryo transfer as defined by error, and also then in first transfers in naive patients, to see whether should we do it right away, or should we have a definite indication before we do intrauterine PRP. So we looked at 40 women with less than 6 endometrium. They had failed, attempts with all other treatments had been given, and those had failed. So they had mixed. Some were post-curetard, some were infective, and some were idiopathic. In Asherman syndrome, we had 4 patients with lining was just 3.4 to 4.8. Now, so what we did was we gave high doses of estrogen from cycle day 2, inserted IUPRP on cycle day 5 or 6, looked at the endometrium. If it had not grown in 48 to 72 hours, we again repeated the IUPRP. And mostly in 25% of patients, twice this PRP was repeated in the cycle. In some, it was repeated even 3 times. About 22% went 3 times. And these ones were the ones who had an endometrium less than 5 millimeters. So once we were able to, get the endometrium to 7 or whatever was maximally achievable, because, I have seen people who keep on cancelling. Patients come to me that, my endometrium is 7, it's very thin, and I've been cancelled. Why? 7 is good enough. 6.5 is good enough. If it is receptive, it will hold the embryo. So I think we should not get stuck on a figure. We have to look at the overall aspect of the patient. If the character is good, that is what her lining was in a natural cycle, well, then that's what nature intended it to be. So we did the frozen embryo transfers, and it was very interesting to see that the mean increase of ET was about 1.4 millimeters. So it was roughly 5.3 on an average pre-PRP, and post-PRP it went up to almost 6.7. Now we had a live birth rate of 48% and a clinical pregnancy rate of 59%. Miscarriage rate was about 18%, but we did have 5 out of these 40 patients where there was absolutely no improvement. And very, very interestingly, these were all the patients who had idiopathic where we could not actually determine any reason for the thin endometrium. There was no pathology. So, that was a little surprising, but that is what we achieved. And then we looked at the RIF group, or we looked at how it behaves for endometrial receptivity. And so we had 3 groups, as I just told you. So in the first group, where we had 3 FET failures, and now these are patients who have received all kinds of empirical therapies like GCSF, prednisolone, what have you, IVIG, whatever, and they still failed with good embryos. So there again, we had a pregnancy rate of 64% and a live birth rate of 49% when we did the transfer post PRP. And then we looked at another group, because I do a lot of ERA. I do personalized embryo transfers, especially if patient has had one failure, the next one always will be done by ERA. Now in these patients also who failed, so we looked at 21 such patients. Their endometrial lining was very nice, above 7.5%, and yet they failed even despite going by the correct window. And here again, after PRP, we got a pregnancy rate of about 68.4. So it is doing something. However, when we looked at first transfers, that means transfer naive, they've never had a transfer, first transfer. This one, my friend had PRP, I want PRP. So, what happens, and then the bias comes in and you start doing PRP for everybody. But when we did it in first transfers, there was absolutely no difference in the pregnancy rate between those who did and those who did not have IUPRP. So patient selection is extremely important when we are taking up a patient for a procedure. If we do it randomly, we will not get a good outcome, and then we'll get disappointed with the procedure. Now, what is the rationale? As we said that, the growth factors allow for cell proliferation, they allow for angiogenesis and, neoendothelial cell generation, they're antimicrobial, anti-inflammatory, and it has been seen that women with RIF have a lower expression of growth factors in their endometrium. But the more interesting study came from Kuroda in 2023, where he did a transcriptomic analysis of the endometrial stromal cells in patients who had received PRP. And this was perhaps the most exciting thing, which I read when it came out, that in the proliferative phase, PRP allows for cell growth, it allows for inflammatory response, it has an antibiotic effect. So you have growth of the endometrium. However, when you're doing it in the secretory phase, or when you do it after starting progesterone, you're doing it for receptivity. And there what happens, cell growth is reduced, inflammatory response is reduced, PI3K signaling pathways are dampened, and this improves your endometrial receptivity and allows for better decidualization and allows for embryo implantation. So both phases had a totally different, action of PRP. So this is perhaps the most interesting part of this, I think, putting in the PRP. So again, after that, we've had a lot of systemic reviews and meta-analysis which have shown that it is very effective. However, women with extremely thin endometrial thickness do have a risk factor, even if they have the endometrium increases in thickness, but they do not necessarily become pregnant. So there is some catch there that has been seen in this particular study. And also women who have had a lot of the more implantation failures they have, the less success you may find with IUPRP, which means perhaps that their failures are not only because at the endometrial level, there may be some other factors involved as well. So for PRP, one of the problems that we have is, though it's very easy, ease of preparation, low cost, ease of administration, but we don't know what is the exact dosage, what is the exact preparation process, should we activate it, should we not activate it, what is the concentration of platelets we should have, and also what are the concerns. You're introducing infection into the uterine cavity. So before you insert your cannula, before you put in the PRP, please ensure that you have thoroughly cleansed the vagina with betadine solution, and then put it so that there is no risk of taking the infection up. And if For instance, one of my exclusion criteria is if a patient has endometrial hyperplasia, history of endometrial hyperplasia, or there has been a polyp, because you're introducing growth factors, I may actually get the patient back into the same stage. And as I said, in adenomyosis, one worries a little bit about the subendometrial administration of this. So these are some of the concerns with IUPRP. Then we have stem cells, and what is exciting about stem cells is they have an ability to self-renew, they have plasticity, they secrete enzymes, cytokines, proteins, and they have what is called a homing ability to find their niche. So you put them anywhere and they will go to their particular niche and then convert or differentiate into that particular tissue or cells that are required. So this is from, mesenchymal stem cells are the one which are most used, and this is taken from the bone marrow. And the aspirate is, there is a preparation technique and an identification technique for this. And of course, what we are seeing nowadays is, haphazard. They take out the bone marrow, centrifuge it, and then just push it into the uterus. That is absolutely wrong and unethical. You have to identify the cells. In fact, you have to actually grow them, incubate and grow them, and enhance them before you use them. But those are some of the caveats, and one has to be careful about that. So they have been put into the uterus directly with the ET cannula, they have been introduced hysteroscopically, or they have been introduced into by an intra-arterial injection into the spiral artery, which I think is the most effective way actually of doing this. And Dr. Naina has done this and achieved success. Now, as I said, it is a promising strategy, but we have to have a thorough understanding of the adult stem cells. We have to actually have good manufacturing processes, and we have to remember that when we are introducing something which has the potential to grow into any cell, we also have to worry about oncogenic element. So all this has to be done in a very, very responsible manner, and one should not just get into the hype of what is going on in the market. So one more thing, and the last thing which I would like to say is that sometimes endometrial receptivity is definitely, or in fact, actually endometrial receptivity is more important than ET. Now, this was a patient, you can see this is from Canada actually. She had an endometrium of 0.3, okay? And on the day of, and if she had an AMH of also 0.3 nanograms. She had IOPRP, and then we tried to build the lining multiple cycles. Finally, on the day of ET, her endometrial lining was just 4.5, but the character was very nice. It was very nice and trilaminar, and she has a wonderful baby with this. So please do not keep on cancelling. Look at the character, look at that, and give the patient a chance to have her embryo put in. 7 millimeters is not sacrosanct. Please remember that. And with that, I'd like to thank you all and conclude by saying regenerative medicine represents a paradigm shift in healthcare therapies. And of course, there is a lot that we still have to learn about them. We have to look at the safety factors, but it's here to stay, and I hope it just keeps improving so that we can help out our patients. Thank you very much.
Thank you, Dr. Nalini Mahajan, for excellent, elaborate, and very much descriptive talk. I will give my comments after Dr. Bharti gives hers. Over to you, Bharti. Dr. Bharti, my co-chairperson.
It's a great honor to chair the session of Nalini Mahajan, ma'am. Really, my day is made. Thank you so much for ISAR for giving me this opportunity. Ma'am, I want to ask one question. You told that 5 out of 40 patients are not improved with PRP. Then did you transfer or cancel?
Some we cancelled. One or two of them insisted on getting the transfer, but then they didn't conceive. And so the other 3, one elected to go for surrogacy, and the other 2 sort of dropped out, so we really don't know what happened to them. But two of them we did the transfer, but they didn't conceive because the lining was very, very thin, just about 5 millimeters. But as I said, that is perhaps not the only factor. Maybe there was something else also which prevented, because we had a pregnancy with a 4.5 millimeter lining. So I can't say that that perhaps was the only factor. There may have been some other factors. We've had one or two patients with a very poor lining where we got the genetic studies done of the patient, and they had some factors which showed implantation failure in the genome. So it could be, I can't
Yeah,
say.
Dr. Nalini,
Yeah.
can I talk? I want to mention 3-4 points what I do. You have told us 7 mm, but I consider 6 mm also with good vascularity. I do the embryo transfer that you have already given us the reference of one case from Canada also. Another thing, I use Ecosprin to not for only to reduce the inflammation or increase the vascularity, but I use it if I use more than for 8 to 12 milligram of estrogen. I use it for avoiding
PVT. Yeah.
or blood
To prevent
clotting
DVT.
factor.
Yeah, that definitely, yes. When you're giving prolonged estrogen, it's very important to keep that aspect in mind.
Before starting low molecular weight heparin. And then next thing is for immunotherapy, I use lymphocyte segregation and I inject it in the endometrial cavity. That gives me very good result for RPL patients. And another thing, I use activated cytokine release serum, ACRS, instead of PRP, because PRP is little vague. You have already explained how it is. Like it is a therapy, it gives result, but the actual protocol nobody knows. And it has got many impurities also. So activated cytokine release serum, there are some sets. With that, I can definitely get amount of growth factor cytokines more than PRP, and it has given me very good result. I inject it like you said that it can aggravate adenomyosis or something like that. But I think if you put the needle inside for a few seconds, 1 or 2 minutes, not 1 or 2 minutes, but few seconds, then it gets absorbed. It doesn't comes out of
No,
your.
it's just my fear. I can't say that it aggravates anything, but it's
It
just
has
my
given
worry.
very
It's
good
my
result.
concern.
Instead of just inserting it like IUI in the endometrial cavity, when you give basal, inject it in the basal layer, it really gives very good results.
I don't know. We have done two patients like that, and I've seen other doctors' patients. I haven't seen any difference. In fact, they have not improved.
IVF repeated.
Therefore, I am not much in favor of, because you're doing an invasive procedure. Every time you cannot keep on repeating hysteroscopic, which is under anesthesia. Whereas the intrauterine, you can repeat as many times as you want to repeat. So I'm not very fond of it. Occasionally, in a very, very bad patient, I may consider one cycle, and then subsequently it will always be intrauterine, because you can't give the patient anesthesia every single time.
No, the repeated IVF failure patient or the really critical means difficult patients. When you do hysteroscopy, I make it a point to do it.
No,
Not
no,
a
that I said, once it's fine, but repeat, you don't like IUI for these very thin endometrium patients, you have to repeat it. It doesn't happen in one go at all. I have never seen it happen in one go in a patient who has a 4 or a 5 millimeter lining. Not yet. I haven't seen anything
Excellent
like
talk,
that
very
happen.
elaborate and very descriptive and very informative. As usual, you have done justice to the subject.
Thank you.
Thank you
Thank
so
you.
much.
Thank you.
Thank you so
Over to
much,
you,
ma'am.
organizers.
Thank you.
Thank you, Nalini ma'am, for the
Thank
wonderful
you.
talk.
Thank
So
you.
Thank you, everybody.
we are moving to our next session,
Yeah.
ovarian rejuvenation. Dr. Fessy, would you like to
Okay,
invite the
I think
chairperson?
next we have got an very interesting session on ovarian rejuvenation. The speaker is none other than Dr. Naina Patel, madam. And for this, to chair the session, we have Gita Kanna, madam, Jyoti Bali, and Priyanka Roy. Over to the CVs of the chairperson. Okay, as you all know, Geeta Khan, madam, is a scientific director, ART unit, high-risk pregnancy unit, and endoscopic surgery unit at Ajanta Hospital and IVF Center, Lucknow, and currently the national advisor of Indian Fertility Society UP chapter, and also founder secretary of IFS UP chapter, and presently the member of the executive committee of IFS and ex-president Association of Private Gynecologists, Lucknow, and ex-vice president of Lucknow ONG Society, and ex-convener of IFS SIG, and also Madam has won several awards and recognition and contributed books and chapters. We invite you, Madam, to this session. And next chairperson is Dr. Jyoti Bali. She is the director of Baby Soon Fertility and IVF Center and fellow of reproductive medicine from the bar and president of DGF Central and founder secretary Delhi Gynec Forum Central and secretary Delhi ISAR from 2019 to 20, joint secretary of National IMA Women's Wing and recipient of Navashakti Award and National Women's Excellence Award. And she's also the Pride of India Award for IVF Expertise in 2015, and also APJ Abdul Kalam Appreciation Award for Delhi Gynecologist Forum. We also invite you, Dr. Jyoti Bali. And next chairperson is Dr. Prengur Roy, ever young and vibrant member from the Siliguri Society, and he is associate professor of Lord Buddha Medical College and Hospital, Saha, I forgot the place name, Saharsha, and consultant in fertility and gynec endoscopy and Roy's Multi-Specialty Hospital, Siliguri. And he is the chairperson of Public Awareness Committee of FOXI, President WATOG, that is Young Gynec Association, and under the FIGO. And he is at present the managing committee member of ISAR and member of Women's Crisis under the FIGO committee. And I think he's a very academically vibrant and received a lot of awards like Foxy Korean Award, Foxy Future Award, AFOG Young Gynecologist Award, Foxy Kamnira Orator Award, Foxy Shanti Yadav Award on Infertility, and Foxy International Academic Exchange Traveling Fellowship, and several other awards. We invite you, Priyanka, also chairpersons, to introduce the speaker. Geeta Khanna, madam.
Yes. At the very beginning, thank you, Dr. Fasi. Such a nice introduction and so kind of you. And I must thank at the very beginning ISAR for bringing up such a beautiful topics and nice speakers. I would like to introduce my friend Naina Patel, and she is known all over world for her beautiful work what she has done. She's pioneer in the field of IVF and surrogacy, and she's president state OBGYN society in Gujarat and founder president of Gujarat chapter ISAR. And Dr. Patel was invited at Oprah Winfrey show. Everybody knows that. Such a beautiful uh, feather on her cap. Then author of number of research papers. Then published and treated world's first case of thin endometrium by bone marrow derived cells. So welcome, Dr. Patel, Naina Patel, and the floor is yours. Come to the dais. He's going to speak on a very beautiful topic. Thank you so much.
Ma'am, you need to unmute yourself, Dr. Patel. Please unmute yourself, ma'am.
Okay, so thank you so much, Dr. Geeta. Thank you, Dr. Fressi, and thank you, ISAR, for having me over here. With definitely a big thanks to UNS and all my dear friends over here. I will be starting my talk right away because I know we are going a little late. And
Late.
ovarian rejuvenation is what I have been doing it for more than a decade. And I will discuss today whether it's a hype or a hope. So treatments for infertility we know are limited. And as soon as we see that there is a limited ovarian reserve, low oocyte count, we may do one cycle and immediately jump onto a donor egg cycle for the patient. But the patients dearly want their eggs to be used. So let us see, is there a role of regenerative medicine? So I'll just start a very recent case of mine. The female 23 years, male 25, 2 years of married life, regular menstrual history. But unfortunately, that husband was diagnosed with testicular cancer. And for fertility preservation, they came to us. 4 semen vials and all of them having occasional sperm with occasional motility. And we froze that. After that, they went for the chemotherapy. Once the chemotherapy and the treatment was completed, they came to us. And as obvious, the husband was total azoospermic now. So we asked them to undergo this IVF and we called the wife. And the wife, to our surprise, the AMH was just 0.42 at 24 years of age. And then there was no point in waiting. We cannot give them more time. We immediately started with the stimulation in February itself. 6 oocyte, 1 day 3 embryo, negative outcome. Now we had only 3 vials left. What to do? Should we go for back-to-back cycle? No. We decided on rejuvenating the ovaries. There was no other reason for low AMH. So we just performed the ovarian PRP and stem cell because this was very important. We cannot utilize all the vials. We repeated the IVF in May 2025. 7 oocytes, 3 embryos, 2 day 3 embryos, AA grade, and 1 we let it go to blastocyst, which was 4AA. We transferred that, and she is an ongoing pregnancy right now. So to me, it is definitely a hope. And this is, I could do it because I learned this from late Dr. Shankar Narayan, who is my mentor and trainer. Regeneration is the process wherein the human's lost specialized tissue is replaced by proliferation of the undamaged specialized cells. Platelet-rich plasma, stem cells, and exosomes. Dr. Nalini Mahajan ma'am described it so well, the platelet-rich plasma and the stem cells both. And now we will see how it also helps in the ovarian rejuvenation, either with PRP, bone marrow-derived stem cells, and in vitro activation. I have not touched upon the oocyte rejuvenation by mitochondrial transfer or by ooplasm transfer. So we know that all this while we were thinking that there is a fixed primordial follicle pool, but now there has been a successful discovery, isolation, and establishment of ovarian stem cells, and that has brought us this hope. Folliculogenesis, a very important part of ovarian function, as it provides the oocytes for reproduction. To prevent that depletion, they are maintained in the primordial follicle stage, but then there comes the activation and the mature follicle. So by rejuvenation, we cannot create lot of new ova or anything, but at least we can get competent oocytes after the activation of the dormant primordial follicles in DOR, POF patients. It can also alleviate some of the side effects of low estrogen. Now the indication we all know is premature ovarian insufficiency or diminished ovarian reserve due to the age. But over a period of time and using it for more than a decade now, I feel that failed fertilization or poor fertilization due to oocyte quality, recurrent miscarriages where there is no other reason for this, unexplained RPL where nothing is wrong except for low AMH, low success rate of fertility treatment. You get good, but they are not fertilized, very low number of fertilization. Then PCO patients we have tried, endometriosis patient we have tried, and now there is a research on post-chemotherapy in the mice also giving good results. Now we don't go into the details of platelet-rich plasma preparation, which has been mentioned, but there are vacuum blood collected tubes available and ACDA, which is what we use, and we centrifuge it and we collect it, we keep the diluent, and I prefer to activate it before injecting inside. And that activation is very important, the timing when we do it. Somehow this preparation, if not done properly, not selected properly, will not give the desired result, and you will feel disheartened that PRP is not working. So read this particular article where it has given how do you define the quality and product of the PRP that you have prepared. It should be 5 to 6 times. Yes, the basic PRP level also should be good. How you will recover the best granules, the best PRP concentrate, and how will you activate them. And again, PRP is also important for the differentiation and proliferation of the mesenchymal cells. Activation, I prefer it, the mechanical activation, and it is activated only at the time when the patient is taken in the operation theater for injecting the PRP in both the ovaries. So once the anesthetist is ready, preparation is done, we activate it, we put it in the liquid nitrogen, freeze it, thaw it again freeze it, thaw it, and then fill up the oocyte retrieval needle, and then we inject it with that very slowly. I'll come to the procedure later. But there are certain articles which oppose it also, and there is one fatal complication after ovarian PRP treatment, which is reported where there was a big abscess, there was bleeding, and it was the reason that it's given a bad name. So these are some of the meta-analyses which are there, which favor or which we oppose it. Now, this Journal of Translational Science has a good article where you can see that how it is an innovative solution for women's infertility. Now, this is our own publication in the Journal of Fertility and Reproduction. It is the promising future of PRP. This is the Aspire journal published in January 2023. We have given our own in-house experience. This was of just 45 patients where 18 were negative, 27 were positive. There were natural pregnancies also, one IUI, and then IVF pregnancy also. And in the IVF pregnancy, we had 6 miscarriages. So this was a good outcome where we concluded that the ovarian rejuvenation by autologous intra-ovarian infusion of PRP can be new potential treatment for females having lower AMH or low oocyte reserve. We should always rule out the karyotyping for POF. It should be normal. We go up to 45 and sometimes on patients incidence more, but after 40, the counseling should be very thorough. This may act, this may not act, and the patient should be counseled repeatedly that whether they really want to go with it. We should not do for autoimmune patient, any patient with malignancy or hypothalamic causes or a hematological disorder. The key considerations, when to plan. Somebody says at the time of retrieval, somebody says immediately post-ovarian, post-menstrual cycle. Ideally, it should be post-menstrual, but if the ovaries are very small and you want to do it, then you can just stimulate it, and when there is a growing follicle, you can see their ovaries beautifully and the cortex, and you can inject it. It has to be injected in the cortex. What dosage? No dosage identified, depends on the volume. At least your PRP count, you can do it. Once you do it, you take a drop and see that it has gone, without diluting it, that it has gone high, 3 to 4 times and 5 times, and then confirm. Dosage for a small ovary could be just 1 ml, 2 ml is the minimum we do. We can go even up to 3 and 4 ml if the volume is good. Then transvaginal laparoscopy, depending on the size of the ovary, whether it is accessible, whether you can see it, whether it is adherent, whether you are doing laparoscopy for other reason like myomectomy or endometriosis. And if it is to be done, ideally all preparation, what is the volume, how will you be doing it, what counseling should be done, what precautions should be taken. Of course, sterility, etc. should be maintained. But when we are doing transvaginally, you need to fix the ovary if it's very mobile so that you do not overshoot or injure any organ. Proper vaginal aseptic precaution should be taken. And prognostic factors, from my experience, I can say age less than 40, reasonable volume of the ovary is there, not a streak ovary, especially if a patient has a past history of conception, even if it's a a chemical pregnancy, or it's a miscarriage or a live birth, secondary infertility, excellent results. Younger the patient, better the result. So this is very important when you are counseling the patient. Ovarian rejuvenation by PRP and stem cells, we inject both transvaginally or laparoscopically, and in vitro activation is one more. I'll do it. I won't go into the detail of this procedure, but as I said, you do it with the oocyte retrieval needle only. You fill it up right up to the end, And then when you inject, we normally now do just 2 punctures only. And when we inject drop by drop and count up to 30, 40, 50 count. And then we just move the direction and do it in the other. You have to allow the PRP to disperse in the ovarian cortex very slowly. It cannot be done in a rush. So take your own time when you are injecting it inside the ovary transvaginally. And laparoscopically, this was our previous technique where we can see the leak. It is coming back. The ovary size is very small. So now what we have started is we go only for 2 punctures. One is the hilar and the other is the anti-hilar. And we slowly keep on injecting. This takes a long time and we see that the cortex really gets blenched. Then only we remove and go to the second point. So laparoscopically is what we prefer the best for the patients. And transvaginally is only for limited, either the patient has come after a laparoscopy or is very young, the ovaries are very easily accessible, then only we do it, right? Then comes the first case which I did. She was a judge from Himachal Pradesh, 2014 I did, AMH 0.54, and she had somehow read about it somewhere. She came to me. We did this procedure. We had only one day 3 embryo and a healthy baby girl was born. But after that, there were very limited number of cases we were doing. This particular patient, again, has very low 0.6. 5 eggs were retrieved, 3 fertilized, and she did not get a pregnancy. She came to us, she wants to try now naturally only. So what else we can do? We suggested ovarian rejuvenation, she delivered. And this was a community where donor eggs is not allowed. 0.09. 0.04, we did the rejuvenation, it went to 0.09. And it took such a long time. It was done in 2019 and she delivered in 2022. So it is said that up to 18 months. How many times to repeat? There are papers which shows that every month you repeat for 3 months. There are papers which show that every time you do egg retrieval. But our experience is once is enough. Very rarely we go for a second PRP treatment for the ovaries. This patient had 2 failed IVF. Husband's male factor was absolutely normal. AMH was not that bad. Age was also 34. We decided to do the rejuvenation laparohysteroscopically and she conceived naturally. Now we go to the stem cells. What are the stem cells? These are the cells which have the characteristics of multidifferentiation, angiogenesis, immune regulation, and parakine stimulation. We know that there are oogonia over here. We know now there is a presumable site of the ovarian stem cell in the ovary. And there is something called as ovarian stem cell nest, and it is the major component of ovarian stem cell niche. Granulosa cell, the most important. Apoptosis of granulosa cell, bed granulosa cell will not give you a good quality oocyte. Vascular endothelial cell, immunological driven molecules. These all will form a area which is surrounding the ovarian reproductive stem cells. And therefore, this niche has now become a key parameter for adequate follicle development to restore ovarian function. And regeneration with mesenchymal stem cells has this property of homing into the area which is damaged or injured. And this will then give immunomodulatory effect, antifibrotic effect, folliculogenesis and regulation of granulosa cell and regulation of angiogenesis. So right from homing in to the development of the follicle, reducing the apoptosis in the granulosa cell, increasing the blood vessel formation, reducing the oxidative stress, and immunomodulatory and anti-inflammatory effect. And this I consider is the most important, the regulation, reduction of the apoptosis and atresia of the granulosa cells. So once they home in, the granulosa cells participate in the follicle development, regulating the ovarian physiology, including ovulation and luteal regulation. So when the stem cells are injected, they will be attracted by the chemokines and then they will integrate into it and then start supporting it with the anti-inflammatory and effect. Multipotent adult stem cells are what we use because it can differentiate only into a limited cell lineage. And there is the bone marrow that we are using over here. Pre-work procedure of the audiovisual consent is taken. about 2 to 4 liter of oxygen is given, IV antibiotic. We give even vitamin C and glutathione. And then from the internal iliac or the posterior iliac or the anterior iliac of the hip bone, we extract it. Normally, it is the anterior iliac. About 60 to 80 ml is ideal. 80 ml should be the best, but we sometimes get even 50. Younger the patient, we don't mind doing PRP, but older the patient with very low AMH, definitely stem cell has a better outcome. There is a manual method. There are automated processing units available to separate it, and then you should count it. But CD count is very difficult. We cannot do it immediately, and in India, we are not allowed to culture it for a long time or induce with some chemical agents. It's not allowed. Whatever cells you separate, it's basically mesenchymal cell separation. And then you culture it into the PRP, platelet-rich plasma of the patient, which you collect it before you do this, and then allow it to grow. Take a drop and check for the infectious disease panel and put it on a slide and see how many cells you are injecting. 1 million per kilogram body weight is the ideal, but even if you inject 15 in both the ovaries, it's fine. There are clinical trials going on, and the ESCOT study by Sonia Harayes did show that there was an improvement in AFC. You will not see an ovarian rejuvenation giving immediately increased AMH. Patient will think my AMH was this, now it is this. No, it is the FSH will go down first, and then the quantity. We cannot say that you give 5 and now you'll get 10 eggs. No, the egg number may marginally increase. Here they have shown that at least it increased by 3 or more, but it will marginally increase, but the quality will definitely improve. And we have also seen up to some patients 3 to 5 number increasing, and that too even after 6-7 months when they come for IVF, we see a better number of eggs than immediately after 2 months. But sometimes due to the age, immediately in the next month also we have to take the IVF cycle. And there are a number of papers which have shown the effect of stem cell. And these are number of papers which are opposing it, that it is not of effect, it is a fiction. So this is our case of patient who had 0.09 AMH, FSH was 14 and age was 30. No other factor for reduced ovarian reserve. When she came to us after 4 years of married life, we immediately did this procedure because she didn't want an IVF. She wanted to conceive naturally. Ultimately, we did IUI and she delivered a healthy baby. This patient, BMI 35, AMH 0.49, HPV 16 positive. We did a laparoscopy, ovarian rejuvenation with bone marrow derived stem cell. Very first cycle in April when she comes again, we did, this is 2023, December. In April, she comes and she has a healthy baby now. This patient surprisingly had a severe fall of AMH during the COVID times. She had previous 3 IUI failed, 1 miscarriage, 2.8 in July, and suddenly in November, she has 0.25. She comes to us, immediately we started the cycle. As a first go, we do not advise ovarian rejuvenation to everyone, unless that previous failed cycle, failed fertilization, poor quality embryos or poor quality oocytes. So we tried 2 cycles negative, and then we counseled her for rejuvenation in January. We waited for good 4 months, did duostim in May when she came again to us, and she has a healthy baby boy with still frozen blastocyst with us. This patient, 39, 25 years of marriage, 1 ectopic pregnancy, 11 IUI, 3 IVF failed. So these are the patient where we will first offer it. AMH 0.8. She came to us. We did a myomectomy was indicated. So laparoscopy, bone marrow stem cell therapy was done. We did her IVF. In second IVF, she got a positive result and delivered a healthy baby. So according to whatever it is, in the right selected cases, ovarian rejuvenation is definitely a hope. Now I will touch the low AMH patients because AMH low and RPL, again, there is a controversy. There is a role, there is not a role. But whenever you rule out everything else and you find that there is a low AMH and patient is getting repeated chemical pregnancy or early miscarriages, we tried this and we selected the cases. It is an unpublished data of 51 patients. It's only up to 22 end, I think. We have got more patients now. We had 27 positive, out of which there were 3 miscarriages and 24 have delivered. So in low AMH, which is responsible for RPL, when you think that patient, when you analyze, you can offer this. Then this is a patient who had 2 miscarriages. AMH was 0.32, 2 IVF failed. We did simply bone marrow stem cell, laparoscopy, hysteroscopy, ovarian rejuvenation. She conceived naturally, delivered in November 2022. And there's a 46-year, 4 miscarriages, naturally conceived, 1 failed IUI, 1 failed IVF in the US. She came to us. We advised donor egg as the US doctor had advised. She refused. She said, "This is my last try. At 48, I'll try donor egg." We did this therapy and she conceived naturally and delivered a healthy baby, although it was a little preterm, 5 weeks early. Endometriosis is another. Now there are mice and rabbit experiment coming for even dissolving the endometrial inflammatory lesions on the peritoneum. But this was an interesting paper which showed that there is both in animal and human models have documented promising results of stem cell based therapy for restoration in this. So we, as a study, we just started clinically how we can help these patients. So this patient from Himachal Pradesh, and it's great for endometriosis.
It's all rubber.
IVF cycles,
Nothing will break.
low quality oocytes, and she came to us. We decided that we should go for laparoscopy, and also at the same time, once the procedure is done, everything is clear, we will go for the bone marrow derived stem cell instillation because we wanted to improve the quality of the oocyte. So the procedure was done, you can see, and once everything was clear, the BMDSC was instilled into the cortex of the ovaries. This was the final picture. Then we called her in January for IVF cycle. We got 5 eggs and all fertilized with even A-grade embryos. We did a day 3 transfer and she delivered a healthy baby girl, and we still have her frozen embryos with us. This is a patient, 37 years, 2 miscarriages, naturally conceived, AMH 0.15, chronic endometriosis. We did the same procedure. She conceived naturally and delivered a healthy baby. Now, in PCOS also, it has been said that human mesenchymal stem cells preserve the capacity to suppress the Th1 response that may influence the internal inflammatory environment of PCOS. So, PCOS inflammatory environment in the ovary is one of the reasons where Th1 is high, Th2 is low, and we want to reduce that, and we want to improve the quality of the oocytes. So one of the methods to improve the quality of the oocytes could be PRP or stem cells. So this patient with 7.7 AMH, LH-FSH ratio was very, very high. I find this is also very important marker. We did her PRP, laparohistoscopy. She had come for a short time. She conceived naturally and delivered a healthy baby. Now I'll talk about in vitro activation. This is for the primordial follicles are what we are activating more. But when the primordial go into the secondary follicle, that is the time when you do the in vitro activation, the oocytes by disruption of the hippo signaling promote the folliculogenesis. So when you disrupt this, the folliculogenesis will be done. So there is Claus Anderson who is now saying again that, but there is Professor Kawamura who still favors it when nothing works. So this is how the cortex of the ovary is removed. And then you see that there is no medulla in it. It is sent to the lab. And once that in the lab, it is cut into very thin slices. It is injected, instilled into the, now what we are doing in the both ovary. When we started with one ovary. Now we are doing for last 2 years in both the ovaries, and we take out from one ovary and then we instill it in the opposite ovary, contralateral instillation. And this is the lab procedure, which I'll not go into the detail. It is cut into real small pieces with a spatial knife, up to 60, 70, 80 pieces from each cortex that you take out. And these are various publications on it. Professor Kawamura was there at our hospital. Before that, we had our first success with this drug-free in vitro activation published in the Journal of Human Reproductive Sciences. And here this female of 34.22 AMH, no reason for low AMH. We did the OTA in one ovary because this was our first case. We didn't want to, see that the other ovary remains safe. Then we did IVF. We got 3 good quality. She conceived, but she miscarried. And we transferred the embryos only from the right ovary where we did OTA. But then again, she conceived naturally after this. And that time the corpus luteum was on the right side and she delivered a healthy baby in May 2022. Now, exosomes are the new kid on the block, but a lot of validation still required. Quite expensive. The cheap exosomes which may be available may not be the right ones, because you have to see and analyze that they are the right ones for this. And finally, PRP, you can do it, but if you want to do stem cell, you should have a CDSCO certificate where they says that you can do it from bone marrow derived stem cells for reproductive infertility cases only. And this is our certificate. I will not show the stem cell lab that we are having, but I will conclude by saying that stem cells definitely play a pivotal role. Platelet-rich plasma is a boon, but please select the right patient, do it at the right time. Preparation technique should be perfect. The activation practice should be perfect, and do not give high hopes to the patient. You have to counseling should be very thorough. Remember which patients can have good results, which patient may not have good results. So a 30-year patient married for 10 years but never had a pregnancy would be not good, but a 35 years old patient with 1 or 2 miscarriages or 1 live birth will be a better candidate. So all this should be important when you are counseling and giving the patient the option. PCOS and endometriosis, we can also do it. And finally, definitely this is a hope and not a hype for the patients who genuinely need it in the best of the hands. And finally, I invite you all for the 30th ISAR, which is happening in Gujarat on 20, 21, and 22 February. I wish to see you all at this conference. Do come to Gujarat. कुछ दिन गुजारो हमारे गुजरात में. Thank you.
Before the chairperson give their remarks, I would like to mention, Naina, your talk was really very nice, informative, and it tells us how much dedication you have in your services in ART, and how much you are keep learning and keep updating your knowledge and treatments for the patients, infertile patient, and all over you get complicated.
Nisha, you were my inspiration for stem cells. Huh?
Hello. Now, so nicely spoken, Dr. Naina, and so variety where we can use it, especially to the persons who can normally conceive. That was wonderful. I really, very much encouraging and very inspiring talk. So many youngsters who have not used that, they will get an insight into it. Thank you so much.
Wonderful lecture, ma'am.
Thank you.
Yeah,
Thank you.
Jyoti. Just a minute, I will give one comment only.
Yes,
Naina, the hemopoietic stem cell, we call it, you are calling it human mesenchymal stem cell for bone derived stem cell. It is actually, I think, in spite of the stem cells, all the material that it contains gives better result with high cytokines and all this masala treatment, which acts more instead of only the mesenchymal stem cells. That is what is my observation is. Yeah, fantastic. You are doing so well. Over to you, Jyoti. Sorry, I had interrupted.
No problem. Very inspiring lecture, ma'am, and good body of work that we could, go through your cases. It was really, really a learning lecture for all of us. Thank you so much.
Thank you, Naina ma'am. It was a mesmerizing talk. A wonderful talk. Thanks a lot, ma'am.
Thank you. Thank you so much. Yeah.
I thank the organizers for giving me the opportunity. I take your leave. Thank you so much.
Thank you, madam. Thank you. So now we are coming to our session 3, panel discussion, management of poor responders. And for this, our moderator is Dr. Rohan Palchetkar. Dr. Rohan CV, please. Dr. Rohan is professor at D.Y. Patil School of Medicine, head of Unit Bloom IVF, head of Reproductive Medicine Fellowship Program, D.Y. Patil School of Medicine, and his chairperson, Foxy Young Talent Promotion Committee, first Joint Secretary, EMOS, Managing Committee member of ISAR.
Anu ma'am, thank you so much for your
Welcome,
kind
Dr. Rohan.
introduction.
Dr. Rohan, would you like to invite your panelist?
Yes, ma'am. I'll just share my slide and I'll invite them. That's not a problem. Would you like to just show me the other panelists' CVs? So I'll just introduce them in short.
इस बार पता नहीं इसार वालों ने कैसे
गीता मैम, आई थिंक आपका माइक चालू है.
इसार में है ना.
Yeah, so my panelists, I've got Dr. Aishwarya Nupur. She's a lead consultant at Iraya Fertility in Hyderabad, and she always keeps herself updated with the latest technologies, and of areas of interest are fertility preservation and RIF. May I have the next panelist slide, please? We've got Dr. Preeti Gupta, ma'am. She's a consultant fertility and IVF specialist at the First Step IVF in Delhi. You can see madam is a gold medalist at multiple levels. And in fact, biochemistry, micro and pharma is something that she's very interested in. She's well trained in routine and obstetric emergency care and has a first-hand experience as a surgeon and first assistant in a wide spectrum of gynecological surgeries. May I have the next slide? I've got Dr. Divya Chaudhary, ma'am, as well. She's a laparoscopist and an ART specialist for over 18 years. She's a member of ISAR, IFS, FOXY, ESHRE, ASRM. She's a fellow from the Academy of Medical Specialties, College of General Practitioners, and you can see the various positions she's held in various organizations. May I have the next slide? Dr. Raju Nair, as you can see, he's a member of ESHRE, ASRM, ISAR. He's a reviewer of the Cochrane network of Sub-Fertility Group, JHRS. He has 14 original articles at index journals, delivered multiple lectures. He's the FNB examiner at CMC Vellore, and his areas of interest are IVF, lab quality, PCOD, and minimal ART stimulation. May I have the next slide? Dr. Spandana Nutakki, she is a consultant infertility specialist at Birla Infertility, Hyderabad. She has an ICOG certified course in critical care obstetrics, and she's also trained in colposcopy, hysteroscopy, and FMF in India certified course in basic obstetric ultrasound. May I have the next slide? Dr. Monisha Singh worked with her very closely during the Young Talent Promotion Chairpersonship. She is her ex-senior residency at Bhu Varanasi, a consultant at Parul and Sarojini Hospitals, Varanasi. And you can see she's won multiple awards as well and a very active member of FOXY as well and ISAR as well. May I have the next slide? Or I think I've finished all the panelists. Please allow me to share my presentation. So thank you so much, firstly, for inviting me for this panel discussion. I know we're running a little late, so I think I'm going to just rush through the CV, through the entire panel, because I think Naina ma'am has covered beautifully the entire poor ovarian reserve and the ovarian rejuvenation. In fact, I have a few similar slides which could overlap it. So honestly, I want to thank all the panelists for taking out time. Just as a statutory warning, I have not given a single slide or presentation to the panelists, so they're going to be answering on the spot. None of them have called me up, so I must thank all the panelists for this. In fact, I want this to be a slightly different panel where I want you to talk about your experience where you have used different modalities, just the way Naina ma'am had spoken about where she has. I want to understand your experience in them as well. So if we know the current trends, there's a focus on career, late marriages, patients are postponing pregnancy for various reasons, there's late consultations, and we have seen that this is an increase in the infertility rates as well. So is infertility affected by age? Now, this is I'm leaving all the questions are going to be open-ended. I would request the panelists to answer one by one and not this. So let me begin by asking Aishwarya ma'am, are you there? Yeah, ma'am, I can see you. Madam, may I request you to unmute and let us know, is age one of the most important factors when it comes to poor ovarian reserve or any patient rather for IVF?
Since childhood, we've been taught, I would call it childhood, that age is the most important factor. determining both the quantity and the quality of ovarian reserve.
Absolutely. Um, I think this is one slide which has been shown n number of times through multiple. Monisha, do you want to just take this slide before I move on to the next one?
Yes, thank you so much for having here. So we all know that this is one of those charts that we have ratified every time, and that has absolutely come in our exams. So it actually tells us that the physiological changes that actually occurs during the age, progression, and what happens to our quality of the oocytes as well as the number of follicles. So we do understand that there's a significant decline that occurs when we cross 35 years. And as we can see that there is a declining fertility and irregular cycles followed by a menopause.
Yeah, I think with the basics of physiology, we all know that this has been there. So if we see how old is too old, at birth, as we know, we have 2 million primordial follicles in both ovaries. But by the time we do hit puberty, there's literally a reduction by almost 1.5 million. And every month we're losing a lot of follicles. And by the age of 40, we're down to 40,000 to 50,000. And at 45 years, it's 5,000. So as we have seen in this slide, oh, sorry. Yeah. So you can see that this continuously changes. I'm going to try and rush through this panel because I know we're already running a little bit late. Raju, sir, could you just give us a little bit of insight into the Poseidon criteria which has been set for the poor ovarian reserve patients? Raju, sir, are you there?
Yeah. So basically, Poseidon is one of the accepted modalities for identifying the poor responder and formulating the plan of action for a poor responder in specifically related to ovarian stimulation. So basically, it's divided into 4 groups. Poseidon 1 and 3 is for the age less than 35, 2 and 4 for age more than 35. So the young group 1 is actually more or less a similar group where the age is less than 35 and AMH is more than 1.2. But the problem group is actually group 3, where the age is less and the AMH is less. And the Poseidon group 4 will be obviously the so-called poor responder. The age is also more, the AMH will also be less. So it gives you a quantification of how to approach the patient with the poor responder. So that will give you a little bit of categorization, how to manage or how to advise or rather counsel the patient that you are in this group so that we can see a prognostication of the success in an ART.
Absolutely, sir. I think it really gives us an insight into how we can plan out our management and also gives us a chance to even explain to these patients who end up getting a poor response at the time of stimulation. Because generally when the AMH is good, we're not expecting this. If this does happen, we do get an understanding. So I love the fact how you very simplified the Poseidon criteria, where your group 1 is a young patient with a normal ovarian reserve but a poor ovarian response. A group 2 is an older patient with a normal response and a normal reserve and poor response. And your group 3 and group 4 are expected poor responders, the young and the old patients clearly. Now, obviously, Nana ma'am has already talked about rejuvenating ovaries, but I want to understand your experience. So we know that we have adjuvants, in vitro activation, PRP, and stem cells. Preeti ma'am, I'm going to ask you because adjuvants is something that almost each and every one of us end up working on or using. So what's your experience with adjuvants? Let me put it in simpler words, what's your favorite masala to use?
Thank you, Rohan. So I've been using testosterone gel, DHEA, CoQ, everything. And when I came for the meeting and read the latest ESHRE 2025 draft guidelines, everything doesn't seem good. There is no use of giving anything. But somehow, although I haven't analyzed my data, I do feel that testosterone gel does help and everything. And Rohan, these are the adjuvants, but I would like to share something very interesting which I recently did. I'm sure everybody would have done. So one of my patients, Dr. Nena was speaking, she had an AMH, she's 33 and she has an AMH of 0.3. So my first cycle was the conventional protocol with I think I used a combination of Gonal-F and HMG, and then we got 4 eggs and ultimately, in that cycle, we got one good blastocyst, but that developed after 136 hours. I did a fresh transfer, it failed. Second cycle, we just got 3 eggs with nothing. The third cycle, I gave her testosterone gel, and then I tried stimulating her with the clomiphene and HMG. No, I think I gave a letrozole and HMG 150, and on day 9, I saw eight eggs, and converted into a high dose HMG 300, and then I got 5 beautiful eggs. We got 3 blastocysts, and we got a pregnancy, and we have got a backup embryo as well. Recently, I gave a Clomid 150 milligram for 8 days with HMG. Day 2 AFC was just 2. And on day 8, when I called her with Clomid and HMG 150 day 2, day 4, we saw 5 eggs. And today I've done a pickup. I've got 5 eggs in a patient I was barely managing 2 or 1. So this
Wow.
is something which I just recently did, and I was very happy. I would share more cases if
I
whenever.
think, Preeti ma'am, that was wonderful what you're talking about. Mild stimulation sometimes for these
Yeah.
patients works
Yes.
much better rather than trying to push that FSH threshold as high as we can. Because we believe that, in fact, I came across a case recently where they used up to even 750 HMG. And I was quite surprised when I heard about that. And because see, whatever we talk about the SRA guidelines, 300 is what they say, beyond which it doesn't really end up working. But I still push my upper limit to 450. And I think most of us do end up pushing up to 450. So in those terms, I think mild stimulation for these patients ends up working a little bit better because we end up
Very
getting
well.
the quality of oocytes as well, sort of like a natural selection more than anything else. Preeti ma'am, you were talking about testosterone gel. Could you tell us what was
Yes.
the dosage you used?
So I have been recently attending the normal dose that I used is 0.1% once daily application in the previous cycle from day 5. But recently I heard somebody from Pune, I would not name him, so he says that I use it twice a day. So in recent couple of patients, I have used a transdermal application, although it's not mentioned in literature. So I thought of giving it a try, and I did try twice a day application, and I did get result. I mean, the number is too less to say. Maybe I'll have to analyze my data. So I've been using it twice a day also, and I did get good results so far.
I
But it's
would want
a
to
small
make a
number.
point here, sorry to interrupt, regarding
Aishwarya.
the testosterone gel. The T trial has already happened, and uh, during that trial, some studies also came up that they've used it for 2 months, couple of months, 3 months as well. So I haven't used it for 3 months, but I've used it for a couple of months. 12.5 milligram BD dose. And in a patient in whom we did not even expect, she's 28, had habits in the past. And then we did a cycle, we couldn't retrieve anything. We put her on the testosterone gel, 2 consecutive cycles. It was not duostim, it was 2 different cycles. We could
Yeah.
retrieve 1 oocyte in each cycle, and we made 10 cell grade 1 in each cycle. So we have accumulated 2 now, and we are about to transfer, and which she had never expected because everybody had offered her donor eggs already. So I think testosterone does definitely sensitizes the follicles to the exogenous gonadotropins.
Absolutely. I think the T trans, in fact, I was listening to another speaker. Again, I don't want to mention the name, but he also said that he uses testosterone twice a day, like a BD dose, and it works very well. Just to all our viewers out there, please remember that you should try and apply it on a part of the body where there is less amount of hair growth. So maybe on the inner side of the arm or on the inner side of the thigh, where there is less hair growth. Theoretically speaking, please counsel your patients that there is a minuscule chance of localized hair growth, even though I have not even seen it in a single patient where I've used a BD dose as well. I personally have used it only for 1 month, not for 2 months. But all the studies which are talking about do sometimes suggest. But majority of these patients where I've used testosterone is a Poseidon group 1 and group 2, as Raju sir said, where we have an unexpected response rather than a the ones in the young, poor ovarian reserve. Divya ma'am, any input that you'd like to give on the other adjuvants? We've talked about testosterone a lot. There's melatonin, there's coenzyme Q10. That's at least what are the drugs I use.
Yes, there are a number of drugs. Like personally, I have been using CoQ10 and that too ubiquinol. I prefer because that is the active form of CoQ. And then resveratrol, 40 milligram daily. And if there is time, like supposing I have some 10 to 12 weeks, then I always start it. Once the patient comes to me, I start it. So like it causes it decreases the ROS inside the ovaries and the granulosa cells and somehow helps in rejuvenation.
Absolutely. I think it really makes a difference when we're using all of this. Now, I'm just going to go quickly through a few studies. I'm not going through the mechanism of actions because I think this is there. This was a Cochrane review in 2024 where it said that testosterone does improve the chances of a successful pregnancy in POR. It said DHEA had no effect on improving the success rates. However, I still do use DHEA. But when I'm using testosterone, I don't use DHEA in combination. And I think everyone would agree on that because it's a precursor. Melatonin is something I use a lot in patients of poor ovarian reserve. I use 3 milligrams at night. Does anyone else use melatonin?
So the patients, especially who are under stress, so melatonin has actually shown a good result. Some mental stress.
So you're also figuring out their sleep schedule who are having disturbed sleep as well. Please remember that a lot of your patients, or at least my patients, do ask, melatonin is a jet lag drug, right? So they always ask us over here. So we always tell them that it has an effect on the oxidative stress. It acts as a scavenger, and therefore it does improve the oocyte quality. And 3 milligrams is a much lower dose, but they should take it about half an hour to 1 hour before their regular sleep cycle, not to take it in the morning. Otherwise, the rest of the day can end up being groggy as well. Coenzyme Q10, again, okay, this is a question that I want to ask, and I want an opinion from all of the panelists. Dr. Spandana, I'm going to begin with you. What is the dose of coenzyme Q10 that you use in patients of poor ovarian
So
reserve?
usually I prescribe 300 mg OD.
All right. Any difference of opinion amongst the
200 mg TDS. That is like the required control.
Sorry, Monisha, could you repeat that?
Sir, we use 200 mg thrice a day, at least for minimum of 2 months prior to the treatment, any treatment that we start.
Okay.
300 BD. There have been a lot of studies with a dose of 600 milligram per day in poor responders where they had showed benefit. So 300 is the preparation which is available. So I usually use 300 BD for at least 2 to 3 months prior and together.
Raju,
Yeah.
sir?
But there is so many. Sorry.
Yeah, basically coenzyme Q, I personally won't use much, mainly DHEA. But if some patients insist, I'll use 300 milligram once daily. But the personal experience is very limited.
Okay. Divya ma'am, you
I
are
use 300. I use
300.
300 OD with
Aishwarya ma'am?
resveratrol, 40 milligram daily.
Okay. Aishwarya ma'am?
Yeah, so reduced form 300 mg OD I would be using.
Okay. I'm personally, again, using 300 mg BD. In fact, there have been some recent papers which are even talking up to using 900 milligrams, but we also have to figure out the cost for the patients because these are drugs which are not exactly cheap and very affording. Because if you look at it, around 10 to 15 tablets can cost anywhere between 1200 to 1800 rupees for a strip of 10, as I said. So even if you're giving BD every 5 days, to spend close to about 1200 rupees over a month is going to increase the cost quite a bit. So sometimes you do have to adjust the doses, maybe use them in combinations which are available as well, and consider that for patient to patient. Now, this meta-analysis which came up with was talking about a few of the masalas, including the other masalas that we haven't mentioned. So what it said was coenzyme Q10 was the only antioxidant with the statistically significant increase in the clinical pregnancy rate and oocytes retrieved. CoQ10 and melatonin were the only two antioxidants which improved embryo quality. This had close to about 2,600 participants. Let me just tell you a surprising fact what I read in this systematic review and meta-analysis. The dose that's required is only 30 milligrams. However, we have to understand 30 milligrams is what it said. However, we have to consider the bioavailability that we do end up getting. So at the end of the day, we have to figure out the bioavailability, and that's going to differ patient to patient in terms of the availability. So that is going to make a difference. In vitro activation, I don't think that I need to talk much about it. Naina ma'am spoke about it quite a bit. I'm just going to play the video what's there. This is not my video. I've taken this off YouTube where it just shows the different steps. I've just edited it to make it short. Does anyone have experience of in vitro activation?
No. So we did a case wherein we removed ovarian cortex and we have cut it into pieces, added growth factors from PRP. The blood was drawn before the patient was taken for laparoscopy. And then in the same sitting, it was injected back into both the ovaries. The ovarian tissue was centrifuged.
All right.
And she had a natural conception.
In fact, this in vitro activation, I've not yet used on any patient yet. But initially, what they did talk about was they used to do it in a two-part surgery. First was that you harvested the ovarian cortex as shown at the start of this video. Then you incubated it in a PIK3 enhancer and a PTEN inhibitor for 2 days, and then had a second surgery to reimplant it. But then they realized that the PIK3 enhancer and the PTEN inhibitor was a little bit carcinogenic. So then now they've come up with this drug-free IVA, which was shown in this, where you harvest the cortex, you cut it into the cubes, create the pockets, reimplant it and do it. It takes about an hour for the entire dissection of the cortex, as Naina ma'am also showed, and then perform this procedure. Just to go over the research papers of this, over here, this was a paper published in March 2025. They had taken about 187 patients of POI, 65 patients with POR. Among the POI patients, they've actually got 10 pregnancies and 8 live births. Among the diminished ovarian reserve, we've got 18 pregnancy and 14 live births. Basically, what the article also said, that it is still experimental. Do not counsel your patients saying that this is a sure shot method in patients basically where they are very adamant about not using oocyte donors. That's where we should think about using basically throwing the kitchen sink at that point at the patient, giving them an opportunity to grow. PRP. Now, this is something I'm pretty sure that everyone has a viewpoint on. Dr. Spandana, can I begin with you? What's your experience with PRP?
Yes, sir. So I'm not very much exposed to intra-ovarian PRP, but I have used PRP for thin endometrium. And it's
Okay.
intrauterine PRP and not even subendometrial. As ma'am initially mentioned, even I am very much scared of subendometrial PRP because I have seen 2 cases post PRP. Like we've just seen huge hematomas in the uterus when we were monitoring the ET. So intra-ovarian PRP, I think it is very useful, and I've seen cases being presented. So I don't have much experience with intra-ovarian PRPs.
Fair enough. Anybody else?
I have used it for my cases like by default, and I have seen beautiful results. For some reason, even like I don't have an IVF clinic, but I use it for my patients who are like during diagnostic laparoscopy, I counsel them simultaneously. Like if I see that there are good chances that I would rather do it simultaneously, but I have seen beautiful results for natural
So
conception.
you prefer doing it laparoscopically?
I do it lateral. I'm not comfortable doing it. Like I don't have the authority right now. I have a non-invasive ultrasound authority for PCP and DT, so I do it like while doing it.
All right.
I have been using PRP quite frequently, like a few of my patients with thin endometrium and with the Asherman's also. Like we have used PRP for every patient. I inject 2 to 3 times, and
Especially endometriosis.
at least once hysteroscopically. And that ovum pickup needle, I use that ovum pickup needle during hysteroscopy. It is so
Yes.
easy to inject
I want to
during
talk more about
hysteroscopy.
the ovary right now because the
And yes,
endometrium.
ovarian PRP also, like, it works. It works because, and I have been doing both ways, transvaginal also and laparoscopic also. But when I'm doing transvaginal, I make it a point to stimulate the ovaries a little, so it becomes a little easy to like see them. Otherwise, during transvaginal, it is sometimes difficult. Small ovaries difficult to see, so I stimulate them. At times, I have stimulated with gonadotrophins also, and then injected. That is what I have been doing. Thank you.
I'm so glad, ma'am, you mentioned that tip because I was otherwise going to ask. Monisha, I'm going to get back to you because you're doing it laparoscopically. Raju sir, have you been using PRP?
Yeah, PRP, I'm little slow with all this odd therapies, very honestly. So of late, one of my colleagues is actually very much keen on, and she is showing all the studies showing improvement of results at poor resolve and all. So with her interest, actually, we started focusing on few patients. Personally, I mean, the evidences are showing that it is beneficial. Previously, it was still a very experimental affair, but now there is a lot of evidence which is coming up. But if you're coming back to my personal experience, very honestly, we did around 4 or 5 cases so far because I am very much skeptical about all these fancy things because unless with the proper evidence, how can we do some experiment? But now I am gaining my confidence and hopefully maybe a year time I maybe will feel more authoritative in saying my crimes.
Raju sir, since you said that you've done it only for 4 or 5 patients, have you been doing it ultrasound guided or laparoscopic?
No, it's laparoscopic.
Okay.
Laparoscopically.
Because under vision it would be more clear. So
Very easy because I actually tried once with during this TVR needle because for an unstimulated ovary, the picking won't be that easy because puncturing into ovary sometimes it will be messy and there's hardly 1 ml or 2 ml of fluid and we don't know where it goes. So maybe some benefit to the patient. So we club with the laparoscopy and we advise that such a poor ovarian response, suppose laparoscopy is done for some other purpose, we add PRP also to the list. So the purpose will be served both.
Absolutely. Aishwarya ma'am, any experience? Have I missed anyone? Preeti ma'am, I want to hear from Aishwarya ma'am and Preeti ma'am about their experiences. Then I have a couple of questions to Raju sir and Monisha as well.
Rohan, I haven't tried much ovarian. I just did 1 or 2 laparoscopically, but I was disheartened because I did not get too many results and then I did not pursue it further. But after this, maybe I'll try it again because so many people have so many wonderful things to say about that. Yeah.
Absolutely. Madam, I will go through the studies and tell you in what cases where we can actually think about using it and what kind of counseling also that we actually need to do to the patients. Aishwarya ma'am, your experience? Madam, you're muted. Aishwarya ma'am.
We have done it mostly laparoscopically, and some cases we definitely found positive outcome, but we cannot attribute or pinpointedly say that it was the PRP, to be very honest. And transvaginally, we did one with stimulated ovaries.
Absolutely. I personally, we've done about 40 odd cases of ovarian PRP. I initially started doing them laparoscopically because obviously under vision, it gets a lot easier to do. And then I've now moved on to transvaginal because it's a lot less invasive unless we have some other pathology during a laparoscopy. Then only I would consider doing an intraovarian PRP laparoscopically. Raju sir, Monisha, and Aishwarya ma'am, since you all three are doing laparoscopically, can you give some tips and tricks about doing it laparoscopically? What kind of needle do you use to inject? How much ml are you injecting into the ovary?
So yeah, basically the first thing is we want to hold the ovary with a grasper or something. So that, and what we use is that there's an injection needle, so that the long needle which we have. So usually we prepare PRP around 4 ml out, and we inject 1.5 to 2 ml on each ovaries. So we'll use it a single point and inject to the subcortical area, and that's all.
Absolutely. Monisha?
Same, sir, but I do it more than once, like one places in single ovary, like 3 to 4 shots
3 or
in
4
0.2
sites.
ml. Yes, sir.
Yes. Aishwarya ma'am, any difference?
So, the KK Surgicals from Mumbai, they've come out with a PRP injection needle, and which is very, I think, convenient to use. And also, the other thing is, we have these people coming from Bangalore to prepare it for us, and they give us cells, then plasma and growth factors. So, I think totally it'll amount to around 2 ml per ovary. And we
Yes.
also inject in 2 to 3 sites and not just a single site. And very slow installation to prevent as much reflux as possible. Stabilize the ovary with a grasper. Yes.
Absolutely. So, just initially, the entire conversation about PRP had started in 2017-18 with Scott Sills publishing his paper on using PRP for menopausal women. So, what basically he had done was he had injected PRP and he said he injected 5 ml in each ovary. But practically speaking, from all of us, you can understand 5 ml just doesn't get injected into the subcortical area. Now, what I actually used to do earlier was when I used to do laparoscopically, I initially did use the vasopressin injection needle in order to inject into the ovary, but sometimes I saw that there was bleeding. And last thing, what you want to do is use cautery on the ovaries. So what I started doing after that was I took the OPU needle, just like an ascitic tap, how you would enter from the abdominal layer. Just enter through the abdominal wall and inject into the ovary at multiple sites, because that the needle is a lot finer, and that way you don't need to. And remember, if any point you do end up having bleeding at any site, put in a gauze piece through the 10 mm port and just give pressure for a bit. Do not use cautery at any point of the junction. Transvaginally, generally you don't end up facing any troubles. What I end up doing is I stimulate the ovaries. If I'm getting any oocytes, I'll actually do a pickup in that cycle and then inject it into the ovary, and that would help as well. So PRP.
Rohan, the needle which you're using now, because initially I also thought this will be a good idea. But which pickup needle you use? Because the pickup needle which we use is a Vitromed one. So the injection stuff is not really easily adaptable. So
I use a single lumen Cook's needle, which I'm
Cook's needle,
using.
okay.
Which I
So
am.
the liver lock will fit it.
So when the Cook's needle is there, where the cap of it, where we put onto the tube, where the suction would generally happen in the OPU, it's got enough space to actually you don't even need to use the syringe. You can, sorry, the needle. You just attach the syringe there and you can push it through that itself. So that makes it a little bit easier to inject it as well. In fact, what Dr. Aishwarya said, I'm using the same intraovarian PRP from Bangalore, where it comes with all the growth factors and all. And being very honest, this PRP preparation is not standardized. This is something that I used to do, but before so I just kept it on screen. But what I have realized that it works only in 20% of the cases. Again, we have to explain to the patients that this is a last-ditch effort to try and attempt where you can actually get your own oocytes rather than going for a oocyte donor. So if again a patient is adamant on using its own oocytes, you have to consider giving them these options. See, all of these are not all of these adjuvants, all of these interventions are expensive. They're not going to be cheap to the patient as well. But I don't think it's our position to actually consider where we consider injecting them. So I think it's our job to at least offer them the options and tell them that they're experimental. But if they do wish to go to use for it, this. Before I just go on to the studies, I also want to know from the people who've used PRP, when do you start stimulation for these patients? Immediately next cycle, wait for a couple of months? How would you go about it? Monisha, could you tell us?
Sir, I to routinely do it, like I do it for my patients like as a preparation kind of thing. So
So if
I
you've
don't
done
do
PRP,
IVF, sir. Yes, sir.
so if
So
you've done
I do it
PRP for
like
this
while
cycle,
preparing. Yes, sir. Like for Asherman cases, endometriosis.
not Ashoman, I'm talking about just intraovarian.
Yes, sir. Like for cases that I'm going for laparoscopically, while doing the ovarian PRP, so I do it for prior to my IUI treatment, sir. So I prepare it like that.
So just in the
I don't do
previous cycle.
IV. Yes,
So
sir.
just in the previous cycle, so you do a PRP and next cycle you're stimulating.
I do it, sir.
Raju, sir?
Yeah, same. Previous cycle.
Aishwarya, ma'am?
So we give the patient nicotinamide, CoQ, and DHA for a month after the PRP, and then we take her up for IVF stimulation. And if she's young, we also allow her to try naturally for 2 to 3 months if they agree, and many a times they agree. And if it doesn't happen, they come back to us in a couple of months and then we start stimulation.
Absolutely. And we're talking about, so basically you're saying that give a 1 month break between the
Yes.
PRP and the stimulation if you're
Yes.
thinking. Preeti ma'am, you said you've used it for a couple of cases. Did you give a break or did you do it immediately in the next cycle?
I don't remember actually because I haven't tried much.
Okay.
I did
Fair.
not find any improvement in the antral follicle count or something. So I just gave up actually.
All right. Which is fair enough. I think it also depends on who's actually gotten success and who's not, which actually, since it's experimental, once you see success, you'll actually end up using it more. But I think till we don't see it in our clinical practice, we would be a little bit on the, yes, disheartened, number one, and on the fence about whether to offer it or no as well. So as I said, we've seen it. I've seen about it working in about 20 to 25% cases only. We've had 3 spontaneous pregnancies out of the 40 patients, and we've seen about 7 patients who've gotten pregnant through IVF after PRP stimulation. I keep a 2-month washout period. So if I've done it in January, the PRP, I give Feb and March as the period for the PRP to act, and I start stimulating in April. This is all discussed with the patient beforehand, before we go in for the treatment as well. And in addition to that, I'll just go through the studies quickly. This was a meta-analysis in May 2024. This showed a spontaneous pregnancy rate of 7%, 18% clinical pregnancy rate, and 11% live birth rate. But these are in patients where OD was recommended, where a donor oocyte would be recommended. So this meta-analysis suggested that PRP could be a viable option in such patients. This was published in Jan 2025. They said that ideal stimulation was 2 months post PRP. However, this was a this case study, sorry, not case study. It was just a single trial center where they did end up having this. So just to give you a little bit of insight into this, what they did was the patients were basically their own controls. So they underwent stimulation in the first cycle. Then they went the control group underwent PRP. Then after 2 months, they stimulated and they compared it, and they saw that the number of oocytes from that same patient was better after PRP stimulation. This was a paper published on July 10, 2025. Again, this was a systematic review and a meta-analysis. It said that PRP increased oocyte yield and increased live birth rate. It said it can be considered as an alternative therapy, not as a mainstay therapy. Regarding stem cells, anybody have experience with that? Okay, so I'm not going to go through that because I think Naina ma'am has spoken about it very crystal clear. I just want to bring about one thing that has been there, which Naina ma'am also spoke about, is stem cell enriched PRP, which has come up, where they actually inject GCSF. This is going to be my last slide. Then I want take home messages from each one of the panelists, where they give GCSF for 4 days and then collect the blood for PRP. However, you have to monitor the leukocyte count daily for the while giving the GCSF, because sometimes you may have to adjust the dose accordingly, after which the PRP is done like how we have discussed, either transvaginally or through laparoscopically as it's there. So here, this was a study which was published in June 27, 2025. It said that the overall activation rate was 70%. It concluded that it's a safe and promising treatment option. However, again, it is still considered experimental. So before we conclude, I want a take-home message from each of the panelists. Let me begin with Aishwarya ma'am. Could you please start by giving us a take-home message?
I believe in synchronization, synchrony. So in the previous luteal phase, I would give estradiol BD from day 21 till menses. I would not prefer she comes on day 2 and I see a follicle already growing and she has barely 2 or 3 and then give antagonist for 3 days because it's suppression and then you need higher doses. So I would prefer pre-treatment with estradiol in the previous cycle luteal phase and offer pooling 2 to 3 cycles. And also, I believe in IVF light, wherein, the how much will you whip that horse, with such high doses? Rather, add letrozole, increases the androgen levels, again, improves the sensitivity, and clomiphene helps in multifollicular growth. So, either of the two we can combine with HMG or REC FSH. And
Absolutely.
pooling should definitely be counseled 2 to 3 cycles. Even if we get one good quality embryo each cycle, and if we can pool some 2 to 3, I think we have good chances. And in elderly, we have again a controversy while pooling whether we should do a PGTA or not because she already has less. Whether we risk them growing to blastocyst is a informed decision to be taken, a discussion. And before doing PRP and any rejuvenation, we have a consent form wherein it says it's experimental and the patient is opting for it, and we get it signed by the couple.
All right. Thank you so much, ma'am. Dr. Preeti Gupta, ma'am, could we get your take-home messages for the panelists? Ma'am, you're muted.
Okay, so yeah, what I would like to share is that as I told you, late luteal, as Aishwarya said, even try long protocols. That also I've seen works. It helps in synchronization. And as I just mentioned that I had a wonderful experience with clomiphene and letrozole in patients who were making very less eggs, and that I would encourage everyone to try that instead of giving a very high dose of gonadotropin because that does give good embryos. And lastly, even I learned, and I would like to try ovarian PRP for rejuvenation as explained by everyone. And let's see in the next panel, maybe I have more experience with ovarian PRP as well.
Absolutely, ma'am. I'm hoping you do try it. Just a word of caution, which I don't know whether I mentioned. PRP, somehow I have seen best results in younger patients rather than the older patients. Sorry, Monisha, if that was your take-home message, I took that away. But Dr. Divya, ma'am, could you give your take-home message, please?
Yes, like whenever a patient of poor ovarian reserve comes, so like revising in your mind the Poseidon criteria, it helps to like customize the patient and to give them a prognosis. And especially for Poseidon 3, like I really feel that long agonist protocol, I'm very comfortable with it, especially for Poseidon 3. And for the group 1 and group 2, like I tend to give higher doses of gonadotrophins. For all poor responders, I use HMG. I sometimes I use double stimulation, and as a trigger, I always give a dual trigger, both. If like the number of eggs, like if they are not hyperstimulated, and they usually don't get hyperstimulated. And then embryo pooling, yes, it can be done if we get less numbers. And for fourth group, for the Poseidon 4, I prefer a milder stimulation. But specifically for third long protocol, this is what I have been doing.
Raju, sir?
Rohan,
Thank you so
can
much.
I say
Yeah,
something?
ma'am, you want to say something?
Yeah, I'm so sorry. I think we've forgotten about recombinant LH also. And in some cases, a combination of recombinant FSH and RLH may also help us.
Yes. In fact, I think there's only one company which is giving that combination currently. I'm not going to take the name, but at the same time, what it does end up doing is there are certain cases where these patients would benefit from them, especially in cases of polymorphism, where you see that in poor responders, I've somehow seen that HMG works equally. In fact, all our gonadotropins work equally well. It again depends on what you're comfortable with and what you're using as well. Raju sir, you want your take home?
Yeah, basically, when we deal with a poor responder, we should give a little bit, don't give a very glossy picture of what our fancy treatment we have. We should give a more realistic picture. Because by all this rejuvenation, we may end up in getting maybe 3 or 4 oocytes further. But will it all translate back to a take-home baby rate is a questionable debate. So we should give that reality pitch to the patient, because patient will try what all things they are comfortable with or that we are telling. But as doctors, we should be a little more evidence-based in practice. And obviously, if suppose this thing's not works, obviously we should give them the option of a donor oocyte program also. So that realistic expectation is one of the basic motto of managing a poor responder.
Absolutely. I think so. That's such a practical way of approaching it as well, and being very realistic with the patient so that they understand where their prognosis lies as well. Spandana ma'am, could we get a take-home message from you?
Yes, sir. So I do believe in synchronization, sir. So I think for that long agonist or double stimulation is also beneficial. And also I have a good experience with growth hormone adding during the stimulation. And as all these are experimental, we need to counsel the patients a lot before even we offer these treatments, because we can't promise them the 100% results. But still, the future is like a combination of adjuvants, PRP stem cells, and AI-based embryo selection. So I think we have to work on it.
I think so as well. I think we end up having to understand. I think each one of us have our own masalas which make our food tastier, as we say. So I think we have to end up not only seeing the evidence but also our experience with which one of these things end up working for us as well. As Amit Patki sir always says, remember, you've been in practice for quite some time, so trust your own gut as well in taking decisions for what you think is right for the patient as well. Monisha, last but not least, I'd like the take-home message from you.
Sir, as everybody has said, but as Raju sir has also said, that we need to keep on counseling the patient about the reality. What they want is like the time to pregnancy to have the baby, or they won't be stubborn enough to try the experimental issues. And we have to keep counseling the patients that there are certain things that have shown a good effect, and there are certain things that are experimental, but they may go ahead and maybe they might be a standard later on. But we need to keep counseling, and we need to give a standard treatment. We need to understand the legality behind every drugs that we are going to inject on those particular patients.
Absolutely. I think, Monisha, thank you for giving a very clear-cut picture on that as well. And I think another thing that I just want to add before we stop this panel is that with all of this, don't forget a word of wisdom which my mother always says, Dr. Nandita Palshetkar: give TLC, tender loving care, to these patients, because they are always coming with a lot of expectations, but at the same time, you'll see many of these patients would have already gone to other centers, had failed results, and come to you as well. So please show empathy. Please also counsel them properly, because that is going to take time itself. So thank you to all the panelists. I've enjoyed moderating this panel, gotten some wonderful insights from each and every one of you all. And I think you all gave some beautiful insights in understanding how to approach these patients with rejuvenation. And I think you all have been able to give some fantastic take-home messages as well. For some reason, my Zoom just disappeared from my desktop. But at the same time, I must say that thank you, each and every one of you all, for giving such practical, on-point insights, which are talking about your own experiences in these patients as well. And also a bigger thank you to all of you all for not asking me the questions prior to the panel discussion as well. Thank you very much.
Thank you so
Thank you so much, sir. Thank you
Thank
so much,
you.
ma'am, for having us over.
Thank you so much.
It was really wonderful to have this session. Really, it's been such a long time, but fertility IVF department is wonderful. It's, God forbid, it's a miracle for every couple out there. And we have already enjoyed the TLC, something that I keep on telling my patients that kyun nahi hoga. There are ways. Keep faith on yourself, keep faith on God, but it will happen for you sooner or later by anyhow.
Okay. Just before we end, I have to thank Anu Agarwal, ma'am, for inviting me as a moderator for this panel. Thank you so much, ma'am, for involving me in this. In fact, this is my second ISAR CME today.
You're most welcome, Rohan. It was a wonderful, wonderful panel, and all panelists were too good. So I think after hearing all this, even I have not injected PRP till now, intraovarian, I think now I would give a try. So it will be
Absolutely.
wonderful.
Absolutely, ma'am. It's wonderful.
I have injected like intrauterine, but not intraovarian. I will try. I will give a try.
Let us know, ma'am, in the next panel when you're a part of it, what are your results?
Definitely. Definitely.
Thank you so much, sir.
Thank you, ma'am.
Goodbye.
Thank
Good night.
you.
Bye.
Take
Thank
care.
you, sir.
Dr. Anu,
Thank you.
if you allow me, I
Yeah.
want to give you a thank you note. So thank you all the expert for being here tonight for the 13th series of our ISAR UNS Fertility Catalyst webinar. Your presence made this event truly special. Lot of insights about the poor ovarian reserve, thin endometrium, and today we had the impressive participation of more than 500 delegates. I would like to extend my heartful gratitude to our distinguished speaker, Dr. Naina Patel, Dr. Nalini Mahajan, and absolutely Dr. Rohan Palchetkar. And special thanks to all chairperson, panelists, and my special thanks goes to Dr. Amit Patki, Dr. Asha Bakshi, Dr. Anu Agrawal, Dr. Fesi for their support. Let's look forward to many more engaging evenings together. Thank you very much from UNS.
So thank you. So we
Thank
are
you.
all glued to screen. It's 9:45.
9:30, madam.
9:30. Oh, that's great. Hats off to you, Rohan.
I tried to save some time. I'm sure everyone wanted to go. I hope you're offline, huh?
RX 17.